So the next four speakers will be part of the meeting segments called What's New in My Specialty, which is always one of the more popular parts of this meeting. Our first speaker is Tyler Christensen. He received his bachelor's degree from Utah State University and then his medical degree from the University of Utah. He did his urology residency at Washington University in St. Louis, Missouri. His professional interests include both adult and pediatric urology, endourology, and reconstructive urology, and kidney stones. He's had several publications. He is a Utah native and currently working at Ogden Clinic. Dr. Christensen.
Thank you. First of all, I appreciate the opportunity I've had to speak today. I get to speak about the controversies of PSA screening, and I'll have to say that this is kind of a special topic for myself because coming from Washington University in St. Louis, late 80s, early 90s is where William Catalona did the early PSA screening studies. The residents said they basically biopsied prostates all day long. And then recently, the American trial, the PLCO, prostate, lung, colorectal, and ovarian, the prostate part of that was chaired by Jerry Andriel, who is my chairman at WashU. We'll discuss the paper that came out last year a little later in the talk. We're going to talk about the controversies of PSA screening. Where do I shoot the next button? Can you guys advance that, or is it? What we're going to talk about today, we're going to talk about first what is PSA, a little about prostate cancer epidemiology. We're going to review some of the recent key articles regarding PSA screening. We're going to talk about some of the national foundations and Institute screening recommendations, and then we're just going to do a quick little talk about the role of robotic surgery in urology. Over the last 8 months here in Utah, in preparing this talk, I've kind of kept me a little running tally of exactly who in Ogden, Utah has prostate cancer to make this relevant. Our first patient was a 47-year-old gentleman, never had his PSA tested. Primary care doctor thought, oh, we should check his PSA. It's first time visiting his doc. Come to find out his PSA was 15.2. He has Gleason 7 disease in all cores of his prostate, and he's currently undergoing treatment. Our next gentleman is a 50-year-old African-American male whose father had prostate cancer. He actually got referred to my clinic for orchitis. I began looking at his PSA. His PSA this year is 1.35. PSA a year ago was 0.63. We did a biopsy on him, and he has Gleason 8 disease. He's currently undergoing treatment. Our next patient, 69-year-old male, he had a PSA of 2.3. On his DRE, digital rectal examination, he noted to have a firm nodule at his right apex. His biopsy shows Gleason 6 disease on the right side. Our last patient, who is somewhat advanced in age, but now in my clinic, is a fairly young gentleman. He had a PSA of 5.5 and 3.9 2 years ago. His biopsy, Gleason 3 plus 4, the entire left side. What is PSA? PSA is a member of the human kallikrein gene family. It's a serine protease secreted in the seminal fluid by the prostate. What PSA actually does cause liquefaction of the seminal coagulum. I tell patients when they talk about PSA, initially the ejaculate is somewhat gelled and then it liquefies. That's what PSA does. In the studying of how elevated PSA is related to prostate cancer cells in and of themselves are felt not to increase the PSA secretion, but the way prostate cancer cells changes the architecture of the prostate causes the local nearby cells to increase their secretion of PSA. Kind of historically, PSA was discovered in the late 1970s. I talked about its clinical practice in the late 80s and early 90s. I mentioned that Washington University with William Catalona was a big part of the early PSA trials. Finally, in 2004, it was approved by the FDA for prostate cancer screening. And this is one of, I think, an important take-home point for clinicians to realize that a lot of our patients with elevated PSA also have BPH, and the medications finasteride and dutasteride can decrease PSA by 50%. So I think it's important when we're screening for PSA, we see patients on these medications to make sure we use some adjustment for the use of these medications. A little about prostate cancer epidemiology. Prostate cancer is common. 1 in 6 men get prostate cancer. It is the most common non-skin malignancy in men, and it is actually the second leading cause of cancer death in men next to lung cancer. The most recent data, 2009, 190,000 men in the United States get prostate cancer, and of those in 2009, 27,360 men died of prostate cancer. Only 2 known risk factors for prostate cancer that we have identified is African American race and family history. So why are there controversies? Why do we discuss PSA testing? Some physicians feel that we should not screen for prostate cancer. First of all, the overdetection and treatment of clinically insignificant prostate cancer is difficult to know, and we have no idea now of telling which prostate cancer is going to be significant and which ones are not. Which ones is patients going to likely die from, and which will they die with. Autopsy studies have shown that in patients over 70 years of age, at least 50% of those patients have prostate cancer in their prostate and die of some other etiology other than prostate cancer. With diagnosis of prostate cancer often comes treatment, and with that treatment comes some significant side effects. Specifically, in younger men, sexual side effects are a big issue, and after surgery there's potential risk of incontinence. With elevated PSA, we quote to patients that usually only 25% of those patients with elevated PSA have a positive biopsy for prostate cancer. And there's a significant cost involved to detect one prostate cancer and to save one life. I'm going to talk about a little later in the European study for prostate cancer screening. Their conclusion was that you had to screen 1,410 men and treat 48 men to prevent one prostate cancer death. Why should we screen for PSA? PSA has led to a downward stage migration. In 1988, a study came out that showed that 19% of patients with a diagnosis of prostate cancer had more than clinically localized disease, greater than T3, T4 disease, and metastatic disease. Recent showed that now with PSA detection, 4% of men present with more than clinically localized disease. So most patients we diagnose nowadays have clinically localized disease, which means it's more treatable and more curable. With the advent of the PSA era, we have things that we now detect prostate cancer 8 to 10 years before it had ever come a problem, and there's a 20% risk reduction in prostate cancer mortality with PSA screening. 2 articles that I'm going to discuss that came out in 2009. The large European randomized study of screening for prostate cancer, the European side, and on the American side, the PLCO, prostate, lung, colorectal, and ovarian cancer screening trial. First, we're going to discuss the European trial. In the European trial, they took 182,000 men, which is a fairly large number, aged 50 to 74, and they randomized the patients to screening, PSA screening, and they said you only needed to get a PSA at least every 4 years versus no screening at all. One interesting thing in this study was their PSA cut point for biopsy was greater than 3. The primary endpoint was death, and the median follow-up was 9 years, which is a reasonable follow-up. The results of the ERSCP trial, 8.2% of patients had prostate cancer in the screening group and 4.8% in the control group. In the screening group, 240 men died of prostate cancer versus 326 in the control group, and their conclusion was that screening decreased the rate of prostate cancer by 20%, prostate cancer deaths by 20%. However, there was no change in overall mortality. They also concluded in this study, which we just recently talked about, is there was likely a high over rate of diagnosis. They probably diagnose a lot more men that have prostate cancer that may not die of prostate cancer. And these numbers we previously talked about, 1,410 men need to be screened, and 48 men need to be treated to prevent one prostate cancer death. The next study we'll talk about is the American study. It was done by the PLCO, prostate, lung, colorectal, and ovarian screening trial. And if you look, the number one author on the paper, Gerald Andriel, he's my chairman from Washington University. And the third author, Robert Grubb, is one of my mentors at WashU. PLCO trial is a little bit smaller, 76,000 men. And they were screened, and this is a little controversial in the study, they were screened to annual PSA testing and DRE versus usual care. And the usual care is a little bit vague as to how that was defined. We're going to talk about in the results why that caused some problems in the trial. Their PSA cut point was greater than 4, follow-up 7 years, and as in the European study, primary endpoint was death. Their results, they actually showed no difference in mortality rate between the screen and the control group. There were 2 deaths per 10,000 in the screen group and 1.7 per 10,000 in the control group. The big problem with this study was that there was short follow-up time and 40 to 52% contamination in this control group. And that means at least 50% of the patient in that control group that got randomized to usual care had a PSA test at some point during that study. So that's somewhat of a flaw of that study. So based upon these 2 studies and what we know about PSA, we're now going to discuss what some of the organizations in the U.S. recommend for prostate cancer screening. We're going to talk about the U.S. Preventative Service Task Force, the American Cancer Society, the National Comprehensive Cancer Network, and the AUA Best Practice Guidelines. The U.S. Preventative Task Forces came out in 2008. And there has been a lot of talk about this, recommends do not screening in patients over 75. And we talked about how we have an 8 to 10 year lead time bias. With prostate cancer, the average American male age 75 has an average life expectancy of 10 years. They did not make a statement about under 75. The benefits of screening for prostate cancer are uncertain, and the balance of benefits and harms cannot be determined. American Cancer Society came out in 2010, and this is what they all recommend. It's important that when we begin screening males for PSA that we do discuss with them and make sure they have an informed decision-making in the process. Rather than the 75-year recommendation, they recommend stop screening if you feel a patient has less than 10-year life expectancy. Because the European study, how patients had at least 1 PSA every 4 years, there's some question if we need to do an annual PSA screening. They recommend that if the PSA is less than 2.5, you can screen every 2 years. If it's greater than 2.5, just screen annually. And as we talked about, screening includes a PSA and a digital rectal examination. We talked about that one patient who had a low PSA but had an abnormal DRE and has prostate cancer. National Comprehensive Cancer Network, their algorithm is somewhat complicated. They have a very nice algorithm on the website. Their recommendation is to begin PSA screening at age 40, and we'll echo that with the American Urological Association. Their algorithm says if the PSA is greater than 1, African American or family history, we talked about the risk factors, to check that annually. PSA is less than 1, another screen at age 45. If you check it at age 45, greater than 1, check annually. Less than 1, you can go to age 50. They recommend annual screening after the age of 50, and then screening over 75, individually determined based upon their factors. I had a gentleman in my office yesterday. He's 83 years old, got sent for a PSA. His PSA was elevated. I'm like, oh, why do I have a guy? Why are we checking a PSA in an 83-year-old guy? But I discussed with him, and his mom lived to 94, so he potentially has 10-year life expectancy. If he does have prostate cancer, that may potentially in the future cause him some problems. American Urological Association agrees with ACS to check at age 40. They do the 10-year life expectancy, and this is something I'm going to spend some time talking about, is there's no single PSA threshold for biopsy. Historically, it's been cut off of 4. That has now been removed. And based upon the European study, the follow-up interval should be based upon patients' risk factors, not necessarily recommending an annual PSA screen. Currently, PSA is as good as we have. Hopefully, there's some new studies down the pipeline that will help us detect who may or may not have prostate cancer. Additional screening tools, we do have percent-free PSA. We say that a percent free of greater than 20% is unlikely to be prostate cancer. Less than 10%, there's a higher likelihood. PSA velocity, if the PSA is between 4 and 10, we say that a velocity of 0.75 nanograms per mil per year is more likely of cancer. If the PSA is less than 4, a velocity of 0.4. You need at least 3 PSAs within at least 1.5-year time span to determine the velocity. Age-adjusted PSA, if you look at the AUA clinical guidelines, there's a very nice table in there. Yesterday in clinic, I saw a 49-year-old with an elevated PSA, and I saw this 83-year-old, and I looked at their PSA numbers, very different. Age-adjusted in a 49-year-old man, you should recommend a PSA, do a biopsy with a PSA above 2.5. The age-adjusted in an 80-year-old guy is 6.5, so that may help. We did speak specifically about risk factors, ethnicity. I would be much more cautious in African American males, and obviously if a patient has a family history, we should have a lower threshold for biopsy. And we cannot underscore the importance of DRE when we're doing PSA testing. Who should get a biopsy? We talked about this historical threshold of 4. There's a recent study that came out that showed that patients with a PSA of 2.5 to 4 can be as high as 20 to 25%. The prostate cancer prevention trial is a very important urological trial. It came back in 2003 by N. Thompson and his group. And basically this study randomized patients to see if finasteride or placebo had a reduction in prostate cancer. They noted a 20% reduction in prostate cancer with finasteride. The interesting thing about this trial is every patient, whether in the placebo or medication group, got an end-of-study biopsy. And in looking at that, 15% of men in this study with a PSA less than 4 had prostate cancer. Because of this, there's a question of where the threshold, and the thought is a lot of urologists now in younger patients, say less than 65, are biopsying patients with a PSA greater than 2.5. I think take-home messages on PSA screening. We should begin PSA screening in men at age 40 to get a baseline. The verdict of when to screen over age 75, there's different opinion in the different recommendations. It's either 75 or 10-year life expectancy. If patients have very low PSAs, we may consider an interval longer than a year for screening. Screening importantly includes a PSA and a DRE, and the cut point of less than 4 is greater than 4 is no longer a cut point for biopsy, and in younger men we should consider 2.5. I just want to take a second and discuss the Da Vinci robot and its use in urology. Yes, ma'am. Yes, so finasteride and dutasteride, they decrease the PSA by half. So after 6 months, you should expect PSA in half. In that PLCO trial, at the end of 4 years, they actually used a factor of 2.3. So you definitely have to keep that in mind. Well, I think you got to give it some time. I think that is definitely a good use. I think the also thing definitely to know that if a patient is on these medicines and their PSA rises at all, that should be a reason to biopsy, because it should cut it in half. The other benefits of that is it does reduce the prostate size in half, so it makes the biopsy too better where we're biopsying more volume. Recently, here in Ogden, Ogden Regional and McKay-D have purchased robots. We are up and running. In urology, we specifically do robotic radical prostatectomies, partial nephrectomy, pyeloplasties, robotic sacrocolpopexies in women. I just want to go over a quick case that's trying to show you how we use the robot and how it works. I had an 18-year-old girl that was referred to my clinic. She was having right flank pain intermittently, and specifically she mentioned after she drank a lot of fluids she had more pain. The CAT scan shows that she had a right UPJ obstruction secondary to a crossing vessel. And if you look here on the CAT scan, here's her enlarged renal pelvis. A couple cuts down, you can see this lower pole crossing vessel causing the obstruction. The way we fix this is with a dismembered pyeloplasty. You basically take here's the crossing vessel. You cut this area off, transpose the ureter over the vessel, and then sew that back together. Here's a little quick video to show that. Can you guys please start that? Here you see the renal pelvis. Here's the ureter coming down. Here's the crossing vessel coming over. This is a robotic arm with scissors. This is a grasper. You have 10 times magnification, and you can see how you have wrists and very precision control with your robotic arms. Here we're transecting the ureter off the ureteropelvic junction. We're transposing the ureter from under the crossing vessel to over the crossing vessel. Intraoperatively, we place a stent. You allow that stent to stay in for 6 weeks to allow that heal up. Using the robot, you're allowed to precisely place the stent up into the renal pelvis. Here you can see using the precision in the arms of the robot, we're tying the knot to complete the anastomosis. I don't know if you've ever sewed laparoscopy. It's somewhat challenging. The robot makes this much easier and precise. Here we're tying down the knot. Then robotically we complete the anastomosis. First we're sewing the front side here. You want a watertight, tension-free mucosal to mucosal apposition. Here we're completing this first knot. After we do the top part, then we'll go under on the back side, sew that. Here you see the back side, and that's the finished product there of a robot assist pyeloplasty. I took her stent out 6 months later. Her renal scan shows a clearance time T1/2 on that side of less than 10 minutes, which shows non-obstructed. Does anybody have any questions? Discussion? Yes, sir.
Whatever happened with using ultrasound in conjunction with PSA and trying to determine the volume of PSA versus
PSA density is definitely something that's been discussed in the literature and can be used. It has little, not much use for the primary physician because, not everybody does ultrasounds, and I think for a patient to subject them to an ultrasound is a lot. I usually use some of these other factors other than PSA density. And I saw a guy yesterday, 2 days ago, I did his biopsy. I put the probe in, and his prostate was 200 grams. Normally it's 30 to 40, so, I don't use that a lot in my practice, but it has been described. Please.
Biopsies are only an elevated PSA. What's the biopsy? Do you take several core needle biopsies?
Yes, sir. Excuse me?
How do you see the actual biopsy? How many samples do you take? Where do you take them? Prostate, if all you have is an elevated PSA but no localized deletion either with ultrasound or visually.
Right. So historically, the PSA, we only did a 6-core biopsy. Now they determined that the best to get the maximum bang for your buck is a 12-core biopsy. We know that prostate cancer forms in the transition, the lateral zones of the prostate rather than the transitional zones. So we specifically biopsy the prostate under ultrasound guidance where we would expect prostate cancer. We also on the ultrasound look for any type of abnormalities that look like there may be a nodule, and we pay specific attention to those areas. Please.
Could you say a bit more about family history? I'm under the impression that only extreme family histories are actually indicative of increased risk. Can you say a bit about this?
Only which family history, sir?
I understand that there's some families with multiple cancers per generation, and that this is predictive of cancer in relatives, but that sporadic cancer is not predictive. Is that
Yeah,
correct?
I usually look, first-degree relatives, siblings, parents. I sometimes go to aunts and uncles, and I think basically upon that, we look at and screen the PSA a little more rigorously and have a much lower threshold for biopsy. Family history definitely is a risk factor. Please.
Just a question about liability and this 10-year expectancy. I mean, being family practice, I mean, there's no way to actually predict that. I'm just concerned that if somebody does live to be 95, we did screen them at 75, they die of cancer at 83. I mean, are we liable in any way? I mean, I would prefer to screen them and send them to you, and you say, don't worry about it.
I agree for you. It's a challenge. I mean, you see a 75-year-old guy that's on no medicines at all versus the guy that's had a heart attack on aspirin and Plavix and limping in with a cane. I mean, it is tough. It's a little vague, and I think right now we almost have to screen and probably go a few years over 75. It's a challenge. Any other questions? Thank you.